Good day, everyone, and welcome to this live webinar on hyperglycemia in pregnancy and beyond. I am Professor Nemencio Nicodemus Jr., and I will be your chair for this webinar. I am a professor at the Department of Biochemistry and Molecular Biology of the University of the Philippines College of Medicine. I have no potential conflict to declare for this webinar. In the next 1 hour or so, we will have 3 learning objectives. 1, to understand how to screen for hyperglycemia and diagnose gestational diabetes. 2, competently manage diabetes in pregnancy. And 3, plan and deliver postpartum screening programs. To aid us in our discussion and learning, we have 2 excellent faculty members. Our first faculty is Professor Rafaela Buzzetti, who is a professor of endocrinology at the La Sapienza University of Rome and is the head of the diabetes unit, Policlinico Umberto Hospital, also in Rome in Italy. Our second speaker is Dr. Ernesto Madaloni, who is an assistant professor of endocrinology and diabetes, also at the La Sapienza University of Rome in Rome, Italy. This webinar is supported by the International Committee by the President of the Latin American Diabetes Association, Dr. Segundo Nicolas Seclen Santisteban. We are also very happy that this webinar is held in partnership with the Latin American Diabetes Association, the Philippine College of Endocrinology, Diabetes and Metabolism, and is endorsed by the Italian Society of Diabetes. It is also very happy for us to know that we have 250 participants from 48 countries who registered for this webinar. So we welcome all of you. Just to run down our schedule for this webinar, after our introduction, we will have our first talk on type 2 diabetes management in pregnancy planning and pregnancy by Professor Rafaela Buzzetti. Then we will have our second talk on the safety, efficacy, and role of metformin in the treatment of hyperglycemia during pregnancy and beyond by Dr. Ernesto Madaloni. And then we will have our panel discussion at the end of the 2 talks. This webinar has been accredited by the European Accreditation Council for Continuing Medical Education with 1 European CME credit and has been certified by the CPD Certification Service as conforming to continuing professional development principles. A reminder to our attendees, please complete the post-webinar survey at the end of the webinar on our e-learning platform to download your certificates. And please select your preferred language because there is simultaneous translation of this webinar to Spanish and Chinese. Also, while listening to our speakers, please submit your questions during the lecture in the Q&A section, and our faculty will address your questions during the panel discussion at the end of the webinar. Just as a reminder, for our participants, we kindly ask you to please complete the pre-webinar survey on the Medea e-learning platform, and you can see the direct link that is available in the chat box. Please fill in the pre-survey online. And this educational program is made possible through the help of Merck from Darmstadt, Germany. And so we now proceed with our first lecturer. Please welcome our Professor Buzzetti.
Type 2 diabetes management in pregnancy, planning, and pregnancy. So good morning to all of you. I can proceed with my first slide. These are my disclosure. The overall learning objectives have been already shown you very well by Professor Nicodemus. So I show my agenda. So I subdivided my presentation in three main topics. First of all, identify type 2 diabetes in pre-pregnancy and in pregnancy. Then the implication for pregnancy and for health of mother and baby postpartum of diabetes, and then the management requirements in people with preconception type 2 diabetes or in those developing gestational diabetes. So, first of all, identify type 2 diabetes in pre-pregnancy. You know that it's very important to screen those at risk for diabetes, and the right time is before 15 weeks of gestation. So test individuals is very important. Who have been to test? In particular, people who are at high risk. These are the criteria from the American Diabetic Association. You know that every year the American Diabetes Association publish the guidelines also about the cutoff and how to identify patient in pregnancy. And this was from Diabetes Care 2024. So what are the criteria for screening for diabetes or prediabetes in asymptomatic adults? First of all, people with a BMI over 25, so overweight, or 23 in Asian American individuals. Then screen high risk race and ethnicity, like African American, for example. Then those who are at risk for cardiovascular disease, who have hypertension, more than 130 for systolic and 80 for diastolic. Those who have low level of HDL cholesterol, or for example, also are very inactive for in regards of physical exercise or other clinical condition associated. So these people have to be tested before 15 weeks of gestation. How to be tested? Screen for early abnormal glucose metabolism with dysglycemia using fasting plus glucose or glycated hemoglobin. Then the American Diabetic Association suggests also the cutoff for screening women already in pregnancy. So screening for GDM is very important for those not previously found to have diabetes or high risk abnormal glucose metabolism detected earlier. And is very important to screen for GDM at 24-28 weeks of gestation. And how to screen? So the American Diabetic Association suggests that possibilities are two. First of all, to perform at the same time. First of all, the one-step 75 grams OGTT. So it is recognized by the Association for Diabetes Pregnancy, and people can be evaluated with just one step. Or, in alternative, we can use the two steps OGTT with 50 grams of sugar, and if the results are positive, then to screen with 100 grams. And this is suggested by the American College of Obstetricians and Gynecologists. what are the different cutoffs in the two different steps approaches? In one step, the first one with 75 grams of sugar, you have to consider, of course, fasting, because if the glucose levels are above 92 at the beginning at fasting, of course, we do not proceed with the OGTT. But if they are below that range, we can proceed with the OGTT, and the results have to be below 180 milligrams DL, or at 1 hour, and after 2 hours below 153. If we perform the two steps strategy with 50 grams, then the test is considered positive. Is after 1 hour, we have a load, sugar load above or equal 130 milligrams. In that case, we have to proceed with a 100 grams of GTT. And these are the cutoff, 180 milligrams at 1 hour, 155 at 2 hours, and 140 and 3 hours. I show you also the flow chart that you use in Italy. I'm very sorry that in Italian, but just I want to ask your attention on two things that we suggest to screen before the 24 weeks, in particular at 16, 18 weeks, those individuals who do not have diabetes but are obese or have a GDM in a previous, for example, pregnancy, have glycemic levels between 100 and 125. So you know that there was also in the American Diabetic Association document that is studied, that is published in the guidelines that are published every year. There is a lot of discussion about the possibility to screen before the 24, 28 weeks, in particular in 16, 18 weeks. The randomized clinical trials are not many on these topics, but the few randomized clinical trials that we have showed that if we use the approach performing the test at the 16-week, we have higher prevalence of GDM diagnosed. However, if you consider the results of clinical trials, the outcomes, the negative outcomes on the pregnant women and on the fetus are not significantly higher starting a therapy, for example, for GDM at 16 weeks compared to the 24 weeks. It is why the American Diabetic Association underline and the possibility to do and suggest to perform the test directly at 24, 28 weeks of gestation. But what are the implications for pregnancy and for the health of mother and baby during pregnancy and postpartum? These are a cohort study from China. 25,000 pregnant women were evaluated in this study. And you can see in these slides the adverse pregnancy outcomes of pregnant women with GDM in age 44 years, subdivided in 5 different age ranges. The figure from A to E show the link between maternal age and the frequency of cesarean delivery, preterm birth, and so on. So you can see, if you consider, for example, the overall women, there is an increase in cesarean delivery in the age range, with increasing age range. The authors used the age range between 25-29 as a control. So you can see there is an increase also in preterm birth with the age, increasing the age, and also in macrosomia, and also in the prevalence of babies with small for gestational age, and also in low for gestational, in large for gestational age, if we consider all together. The maternal age in GDM women is an independent factor of risk for some complications for the mother and for the baby. In the same study, authors show this picture, and here there is the GDM number and prevalence in China of pregnant women, and the graph shows the prevalence that the prevalence of GDM rose with maternal age, and the number, the absolute number is shown by a bar card, and there was an increase in the number of complications. But you can see that the rate is the line show the increasing in the rate with the maternal age. So the authors demonstrated that the maternal age is a very important factor in GDM for complication for the baby and for the mother. This study was performed in women with GDM, but also with women with diabetes pre-pregnancy with type 1 or type 2. Was a case-controlled study performed in 200 subjects with GDM or type 1 or type 2 diabetes pre-pregnancy, and in approximately 200 women in pregnancy without diabetes. As you can see, for different pathologies in pregnancy, there is a significant increase in subjects with diabetes, and they reported the odds ratio, and the significant difference compared to the control. As you can see, for example, in the treated abortion for type 2 diabetes, there is an odds ratio of 80, and it was highly significant compared to control. And also in the treatment of preterm birth, there was a significant difference concerning in particular women with type 1 diabetes. And also in hypertension, for example, there was a significant for type 1 diabetes and GDM. If we consider preeclampsia, there was a significant difference in women with type 1 diabetes and GDM compared to control. And also for the delivery, for example, if we see the section, cesarean section, there was a significant increase in all forms of diabetes, and also in preterm delivery. And also in the neonatal outcomes, where there was a significant increase. Here we have all women with diabetes, 207 compared to control. And if we consider the fetus large for gestational age is significantly higher, 22% compare 8.7 in control group. Also, the respiratory disorders were significantly higher in the case group compared to control, but also, for example, the phototherapy or the neonatal jaundice and the anomalies, morphological anomalies were significantly higher. And also, if we consider also only the women with GDM, excluding those with type 2 and type 1 diabetes, there was the fetus large for the gestational age was significantly higher in women with GDM, and also the respiratory disorders, and for example, neonatal hypoglycemia, 20% in women with GDM compared to 5% in the control group, and also with other abnormalities. This is a very interesting epidemiological study very recently published in Lancet, where authors analyzed the complication amongst pregnancy complicated by GDM in women from different countries. As you can appreciate, for example, if we consider the cesarean delivery, in the US, in people, in women with GDM, we have 40% of cesarean delivery and 30% approximately in France, for example, 52% in Brazil and 60% in South Korea, and 26% in Qatar. So, for example, if you consider preterm delivery also is approximately 10% all over the world, only but was in Ethiopia, for example, 22%. If we consider infant outcomes, for example, neonatal intensive care unit admission was 11% in the States, and in China, 14%. We do not have data in some states. It was 16% in Australia and 23% in South Korea. And so on in other disorders like hypoglycemia, for example. And this is a very important, I think, review, and because it shows, it's able to show new data and very recent data all over the world. So what about the neurodevelopmental alteration in babies? What are the implications of GDM or type 2 diabetes? We have immune adaptation that can determine maternal adaptation in with when glucose levels are high, and so that are fetal also determine fetal adaptation, increase cytokines, increase adipocytokines, disruptor synaptogenesis. Then we can have anemia, maternal anemia, reduced oxygen flow, fetal acidosis, and disrupted fetal monoamine neurotransmitters that can determine reduced brain-derived neurotrophic factors and determine disrupted dendritic cell architecture. We can have a lipid abnormality, so a maternal lipid profile abnormality, high omega-6 fatty acid, and it can determine fetal hippocampal alterations. Then we have also changes in as far as the epigenetics is concerned, so lipoprotein lipase methylation, for example, miRNA dysregulation, and so also clinical symptoms like motor impairment, cognitive disability, autism, language disability, and so on. This study, published in Nature Review Endocrinology in 2019, showed two data sets. And the first one, before the use of therapy, of any therapy in pregnant women with diabetes. And the second one, after, show a population-based course composed by pregnant women who were treated for their diabetes during pregnancy. So as you can see, for example, the large for gestational age infants decreased from 62.5% to 42%. Preeclampsia decreased from 18% to 9%, and preterm delivery decreased from 42% to 70%. It means that the treatment is very important during pregnancy because the complications significantly lower if the women were properly treated. So it introduced the last part of my presentation, the management requirement in people with preconception and those developing gestational diabetes. So the preconception counseling very important, set at puberty in people and continuing women with diabetes and reproductive potential. So family planning should be, of course, discussed. So pre-pregnancy care, multi-target approach, lifestyle, we have to ensure 175 grams of carbohydrate have to be maintained for the fetus. Pharmacological insulin therapy is the generally preferred therapy for diabetes management. I don't speak about metformin because Professor Maddaloni will show you all studies about relative to metformin later on. And of course, to prevent severe hypoglycemia and DKA. So what are the targets we have to ensure in the and reach in the mother during I report here the different guidelines and the cutoff of the different guidelines. We have 1 hour postprandial glucose below 140 and 2 hours below 120. And the first one are the more diffuse guidelines. And so when this is also the guidelines at which type of drug we have to use. So which type of drug? These are very interesting trees. I don't want to go inside all different steps, but the blue box represents greater likelihood for successful control with dietary exercise modification. Green boxes represent greater likelihood for recourse to insulin treatment, and T0 and T60 represent the baseline and the 1 hour blood glucose values respectively. For example, in these different classification trees, you can follow to recognize which are the risks to have insulin therapy. So this is the insulin therapy we should use, rapid insulin. I want just to remind Lispro and Aspart are the most diffuse insulin, rapid-acting insulin used, and long-acting insulin have to be used, determined glargine, U100 and U300 are the most used insulin. I have just a couple of slides to conclude. Dosing recommendation, you have to consider 0.7 unit kilograms day through the first trimester, increasing to 0.8 units for kilograms day around weeks 14-18, increasing to 0.9 during 26-27, increase to unit 1 kilograms around weeks 36-37. This is the insulin recombinant pregnancy in type 2 and in type 1. You can appreciate the JDM type 2. There is much use of insulin at the end of gestation. You have to use, I suggest to use the CGM because of great value, because the CGM is recommended, is good for both mother and infant use. There are a lot of countries where we are starting to use CGM during pregnancy complicated by diabetes. And screen individuals postpartum with 70 grams of GDT after 4 to 12 weeks And of course, it's very important. And the cutoff are exactly the same we have in people with high pregnancy. My last slide, so gestational diabetes treatment is very important. Nutrition is one of the most important things. Protein, carbohydrate, 170 grams of carbohydrate. Physical activity, try for at least 20 minutes per day. Insulin is the first treatment, but also metformin. And with this, I thank you for your attention, and I give the word to Professor Nicodemus.
Thank you very much, Professor Busetti, for discussing with us the management of type 2 diabetes in pregnancy planning and pregnancy. Indeed, we learned a lot from you. For our audience, please type in your questions in the chat box or in the Q&A. And as we proceed to our second lecturer is Professor Ernesto Madaloni, and he will discuss with us the safety, efficacy, and role of metformin in the treatment of hyperglycemia during pregnancy and beyond. Professor Madaloni?
Thank you, Professor Nicodemus, for your introduction, and I also would like to thank Medea for organizing this very nice webinar on a crucial and very important health issue that involves not only pregnant women, but also the offspring, as Professor Buzzetti has already highlighted. These are my disclosures. And now on the screen you can see the learning objectives that the scientific committee organizing this webinar has asked me to cover. So we will go over the main results of the most important randomized controlled trials testing metformin during pregnancy, and we also will evaluate the long-term follow-up data that derives from the follow-up studies of such trials with regards to both maternal outcomes and outcomes in the offspring. This is the agenda of my presentation. I have just one slide on the guidelines, which have been already in part discussed by Professor Buzzetti, and then we will go over the trials and focusing then on the neonatal and maternal outcomes. The guidelines. Why I'm showing you this very busy slide with all the different guidelines? To highlight that in different countries and different timing of the guidelines have bring two different recommendations. For instance, in 2015, the NICE, the National Institute for Health and Care Excellence, already suggested that metformin might be a first-line treatment, possibly also in addition to insulin, in women with gestational diabetes. However, this position is not the same in other countries. For instance, the guidelines from our society, the Italian Society of Diabetes, in 2018 highlighted that insulin should be the treatment of choice, and at that time metformin was a standby. But I will also show you that last year our society has also written a position paper about use of metformin, which has been updated based on the results of the trials I'm going to show you. The most recent guidelines of the American Diabetes Association, however, different from what the NIC was saying in 2015, suggested insulin as first-line treatment and metformin as possible second line. Our position statement in 2023 were balancing the benefits and the risk from using metformin during pregnancy. So overall, there is quite a large heterogeneity in the guidelines recommendations about metformin. Why this happened? And let's see how the data from the clinical trials may help us as the end users of such recommendations to make the right choice for the right patient. The first trial I'm going to show you is the MIG trial. MIG stands for metformin in gestational diabetes. I will go over all the trials using more or less the same slides, which show you the P, which stands for population, so the people that have been enrolled in that specific trial, which is very important to consider when we look at the results of randomized controlled trials, because that results should be used for that specific population with that characteristics. E stands for intervention, so which is the intervention we are going to test in the trial, and for all the trials, of course, the intervention will be metformin. C stands for comparators, and O stands for outcomes, which is the primary outcome of the trial. So the MIG trial enrolled more than 700 women with gestational diabetes, which was diagnosed after 20 weeks of gestational age. The intervention was metformin, which was compared with insulin. The outcome was a composite of neonatal hypoglycemia, respiratory distress, needs for phototherapy, birth trauma, and the Apgar scores or prematurity, which are all the adverse outcomes that may happen into the offspring of women with gestational diabetes, as highlighted in the previous presentation. The MIG trials already in 2008 showed us that in terms of the primary composite outcome, using metformin or using insulin had no significant difference. You see that the percentage, the relative risk is 0.99, so the two interventions, metformin and insulin, were quite the same. However, if we go within specific outcomes of the trials, we see that there are some differences between the two different groups. The metformin group, for instance, had a lower rate of hypoglycemia, which was defined as any blood glucose levels lower 28 milligram per deciliter in the in the offspring. However, there was a slightly increased risk of preterm birth within the metformin group. So you see that there are, overall in the composite outcomes, they are the same, but we can start to get some specific information which can help us to prioritize some treatment in a specific women depending on the risk of that specific outcome. In terms of secondary outcome, also the MIG trial shows that the women randomized to metformin had better postprandial capillary glucose levels, and also gain less weight from enrollment to the end of gestation compared to women randomized to insulin. So other important information helping us to personalize the treatment. In 2020, another important trial, so there has been a long period from the MIG trial to the MEAT trial. The MEAT trial was evaluating metformin in women with type 2 diabetes in pregnancy, which we know is a different disease from gestational diabetes. In this case, type 2 diabetes in pregnancy was defined as women with the diagnosis of type 2 diabetes between the 6th and the 22nd week of gestation. Intervention was metformin, in this case on top of insulin, compared to placebo on top of insulin. So in this case, metformin was not given compared to insulin, but as an adjunctive therapy, as a second-line therapy on top of insulin. And also in this case, the outcome was a composite of both fetal and neonatal outcomes. In this table, you can see summarize the main results of the trial. So again, there was absolutely no difference from using metformin or not using it in terms of the composite primary outcome. However, there were some differences in terms of the birth weight associated with the use of metformin. Again, not in gestational diabetes, but in women with type 2 diabetes in pregnancy. In these women, there was a significantly reduced risk of large for gestational age associated with metformin. So using metformin decreases the risk of this adverse outcome highlighted by Professor Buzzetti as an important adverse outcome during pregnancy. But on the other hand, since overall there was a decrease in the birth weight of the mean birth weight of the offspring of the mothers randomized to metformin, which is also highlighted by this histogram on your right, where you can see the different birth weight zeta score on the x-axis in metformin, women randomized to metformin compared to women randomized to placebo, and you can see that the zeta scores are more on the left, so reduced among women randomized to metformin. And as a result, the MITI trial also highlighted an increased risk of small for gestational age among users with metformin. What is small for gestational age? Which is actually probably the most frequent and most important complication, if not the only complication associated with the use of metformin in pregnant women. So small for gestational age is a condition which is defined by a birth weight which is below the 10th percentile, or in case of severe small for gestational age, below the 3rd percentile of weight, or less than 2 standard deviation from the mean weight of that gestational age. Is it an important condition? Yes, small for gestational age is an important pathological condition because it is associated with perinatal complications, and you can see some of these perinatal complications on the screen, and with also some adverse outcomes in the long term for the offspring, such as metabolic syndrome or precocious puberty. But what are the risk factors of small for gestational age in pregnant women? There has been a very nice systematic review and meta-analysis published in JAMA in 2017, showing that the most important risk factor for small for gestation age is that a low weight gain during pregnancy of the mother. We know that for mothers have to gain weight during the pregnancy. There are recommended parameters, recommended ranges of weight gain based on the BMI. So there are BMI specific weight gain ranges, and if the mother acquires less weight during the pregnancy, then which is recommended, there is an increased risk of small for gestational age, which of course is the opposite if we see increased weight gain. One of the possible explanation of the increased small for gestational age risk highlighted by the MITI trial is probably the fact that overall the weight gain for the mother randomized to metformin has been lower than those randomized to placebo, both overall and the weekly weight gain, which was also associated with a lower total insulin daily dose. So probably we can monitor the risk for small for gestational age by monitoring the weight gain of the mother, and reduces this risk by avoiding a reduced weight gain for the mother. Another trial, which was published last year, always in JAMA, so this also highlights how this topic is important and relevant to the healthcare community working in diabetes, and not only in diabetes. Randomized more than 500 women, in this case with gestational diabetes, to metformin or placebo early during their gestation, so before the 28 weeks of gestation. So the trial was designed to evaluate whether an early randomization to metformin was associated with a reduction in a composite outcome of insulin initiation or high fasting blood glucose. The trial was successful in the primary aim because using with metformin was associated with a reduced time to insulin initiation and also with the reduced level of fasting blood glucose compared to placebo. In terms of secondary neonatal and maternal outcomes, the trial showed that the use of metformin was associated with benefits in terms of large for gestational age, so confirming all the data that we had from the previous trial, such as the MITI trial, but in this case there was no significantly increased risk of small for gestational age. In terms of maternal outcomes, women randomized to metformin had lower hemoglobin A1C and a lower weight gain compared to people randomized to placebo. Another trial, important trial, again published in JAMA in 2023, was the MONPOD trial, where metformin was added on top of insulin, so as a second-line treatment, in more than 800 pregnant women with a pre-existing diagnosis of type 2 diabetes. So this was similar for design to the MITI trial. Again, on the outcome was a composite of neonatal outcome. And again, the use of metformin was not associated with an increased risk of any of these outcomes, which was similar to placebo. And again, there was a consistent reduction in the decrease of the risk for large for gestational age, and again, the increased risk for small for gestational age, which was observed in the MITI trial, was not confirmed in this MOMPOD trial. So overall, if you want to see an overview of the main results of the randomized control trial, but also of the observational trials that have been published so far. This is a meta-analysis published in 2024 about use of metformin in pregnancy. We can see that there is an overall agreement in a decreased risk for large for gestational age associated with the use of metformin. There have been two trials, the MITI trial, which is the largest one, and also another small trial, is resulting in increased risk for small for gestational age, and there is overall a decrease also in the risk of admission of neonatal intensive care unit associated with the use of metformin. In terms of maternal outcomes, there is an overall agreement, in fact, that use of metformin is associated with a decreased risk of weight gain, and also with some differences in terms of cesarean section and glycemic control. What about the long-term outcomes associated with metformin? So the MITI trial has been followed by a 24-month follow-up of looking at the outcomes in the offspring. This study, published in the Lancet Diabetes Endocrinology in 2023, showed that there was no differences in the BMI growth trajectories up to 24 months among babies who were exposed to metformin or not during their intrauterine life, if they were female. But if they are male, there has been a small increase in the BMI of these babies, especially during the first year. So let's go back. Especially during the first year, but then there was no difference at 24 months between exposed and not exposed to metformin. Also, the MIG trial has been also participants in the MIG trial have been followed up in the MIG TOFU study. In this case, the follow-up was longer, and the outcomes, the metabolic outcomes, were collected at 7 and 9 years in the offspring of women with gestational diabetes. And the MIG TOFU trial showed that there was just a slight increase in the BMI, which was not statistically, but close to the statistical significance in babies who were exposed to metformin compared to those who were exposed to insulin, which was, however, associated with both an increase in free fat mass and total fat mass. So it's not just a matter of fat. Overall, this increased risk of BMI, which may be associated with metabolic syndrome, could also be associated with the small for gestational age issue, because we know that the children that are birth smaller than the expected weight have an increased risk of metabolic syndrome, and this is shown here in this meta-analysis with 20% increased risk. What about the postpartum maternal outcomes? We have data in this case not from an intervention trial, but from an observational study looking at maternal outcomes of women that were exposed to metformin or were exposed to insulin or diet. And this study showed that actually there was no significant difference between metformin and other treatment in terms of long-term maternal outcomes. So in conclusion, The data that I have showed you clearly, in my opinion, suggests that use of metformin could be a valid therapeutic option for treating hyperglycemia during pregnancy. There we have now a large amount of data from important clinical trials, a large clinic were published and large randomized clinical trials. So we have now data on which we can rely. Women treated with metformin have a better glycemic control, lower insulin requirements, and less weight gain during pregnancy. In general, women prefer metformin to insulin injection. And lastly, with metformin appears to reduce risk of large for gestational age and neonatal hyperglycemia. However, we should always keep in mind when we use metformin that there has been shown an increased risk for small for gestational age, which we should monitor, we should avoid, and that this risk might be then related to an increased risk of increased BMI in the offspring during the long term. I would like again to thank you for your attention and to thank you, the scientific committee, for giving us the opportunity to talk about this important topic, and I will be really happy to take any question.
Thank you very much, Professor Maddaloni, for discussing with us the effect of metformin, the safety, efficacy, and its role in the treatment of hyperglycemia during pregnancy and beyond. Indeed, we learned a lot, especially the different trials that utilized metformin among this group of women and the offspring, the outcome in the offspring. I would like to encourage our participants to continue to send in your questions. Please write them down in the chat box or in the Q&A so that our speakers can answer your questions. Okay, we do have a couple of questions here that I would like to ask our speakers. For Professor Bussetti, if a woman is expecting to become pregnant and has a family history of type 2 diabetes, what procedures should be done?
Thank you very much for this question. It is very important. As I told you at the beginning of my presentation, at more or less 15 weeks before pregnancy, she should perform an evaluation of glycated hemoglobin and glucose levels at fasting. And in this case, you can understand if it is a risk of diabetes, is in a range of dysglycemia or prediabetes, or it is completely normal. So in this case, if is, for example, the fasting glucose is above the range, of course, she has to be treated with diet and exercise, because it's very important to start a pregnancy with a very good value and the right value within the normal range.
Thank you very much, Professor Bussetti, for clarifying the answers to that question. For Professor Maddaloni, the question that we have is, how can we predict the risk of small for gestational age among metformin users? Is there a way for us to predict this?
Thank you very much for the question. So this is a very important and crucial point, I guess, because actually it has been probably the only real adverse effect associated with metformin. So there are no clear data that associates a specific phenotype of women, for instance, to the risk of small for gestational age associated with metformin. But what we do in clinical practice is that we have to strictly monitor the woman and during pregnancy for the weight gain. I showed you the data that in general, not just metformin users, but in all women, there is an increased force mode for gestational age if the woman does not gain the right amount of weight. So we have to monitor our patient and ensure that the right diet is performed and that our patient is gained the right amount of weight. And as well as we also have to monitor the intrauterine growth of the fetus. And at the first signal that something is going wrong, that the growth is not as we expect, we can probably think about other therapeutic opportunities. Another thing that we should think about probably is the phenotype of our women, because this more for gestational age seems to be also associated with the activity of insulin on the fetus. Okay, so if we have GDM women with an insulin deficient phenotype, we know now there's been a very nice paper published in Nature a few months ago showing that there are two different phenotypes, insulin deficient GDM and insulin resistant GDM. So in that case, probably we can try to personalize our treatment based also on that phenotype.
Thank you very much, Professor Maddaloni, for your answer to that question. We have another question, this time again for Professor Bussetti. If a woman puts on too much weight on the first trimester of pregnancy, do you suggest performing an OGTT before the 24th week of gestation?
Yes, thank you very much for this question. There is still a very interesting debate about what is the right time to perform the OGTT in pregnancy. The American Diabetic Association still suggests in the last 2024 guidelines to perform at 24 and not before, because the explanation was because there are not enough clinical trials demonstrated that starting a treatment at 10 weeks, 14 weeks or 20 weeks, the outcomes, the negative outcomes are significantly lower compared to starting the treatment at 24, 28 weeks. However, in Italy, for example, and in other countries, if the pregnant woman is at risk, we perform the OGTT at 16, 18 weeks of pregnancy. So it is what I suggest, because in very, very recent paper, I show you the epidemiology paper on Lancet, also another one published in 2024. The idea was to anticipate the treatment, because an early treatment is correlated with better outcomes in the last very recent trials. So at the end, I answer your question saying that it's better to perform before the 24 if there is a person at risk. Can I ask something to Professor Maddaloni about metformin?
Sure.
Yes, go ahead, Professor Bussetti.
Yes, because he told us that very recently a paper demonstrated that in JDM there is some women that are insulin deficient, other one that are insulin resistant. It makes a lot of sense, because some women are at risk for type 2, and maybe they are the majority. What about MODY? Because we know that 15, 20, but also more that percentage of women with MODY are diagnosed in pregnancy. And depending on which type of MODY they have, maybe they should be treated with diet alone, with metformin, or with insulin. So do you think that we lose a lot of MODY women because we do not perform genetic tests as we should do in for pregnant women?
Absolutely, thank you. This is a really well taken point, as usual, Professor Buzzetti. As you said, many MODY, many patients with MODY have their first comes into our clinic and that have their first presentation of diabetes during pregnancy. So unfortunately, there has been in the paper that I just mentioned before, there was no specific investigation for this, which is probably an important bias of an important limitation of the paper. And also in the trials that I showed you about the use of metformin, there was no screening for MODY. It was just the diagnosis of gestational diabetes. So this comes probably to our expertise right now to try to identify and to suspect the presence of MODY based on a complete analysis, a familiar analysis and collection of data, family data, and try to suspect the presence of MODY based on that, and based also on the age of the patient and all the other risk factors. Let's say if I have a patient that developed gestational diabetes, but she is young, we know that the risk of gestational diabetes increases with age. There is no very high BMI, for instance, and we know that the risk for gestational diabetes increases with the BMI, and that all the other risk factors that you showed us are not present in that patient. So in that case, we should probably think about MODY. And it is very, very important because if we think about MODY, in my opinion, we have no trials, but in my opinion, metformin might not be the right drug because most of the genetic modification associated with MODY are related to the secretion of insulin. So that may be the main reason of their hyperglycemia during pregnancy. So an insulin deficient phenotype and not an insulin resistant phenotype, probably.
Of course, unfortunately, we can't use sulfonylurea, so in pregnant women, so we have to use insulin.
Sure. But this is important also to identify all the patients that may safely take metformin. So this comes back to the precision medicine approach, which was probably my first word during my presentation. It is important to find the right patient for the right therapy, and just looking deeply into the trials and into the population that has been in the trials, we can get this information.
Thank you very much, Professor Bussetti and Professor Maddaloni. Unfortunately, we don't have time for additional questions, but I will tell everyone, and I'm sure everyone will agree with me, that we did learn a lot from our two excellent speakers for this webinar. Thank you, Professor Bussetti, for reminding us on how to screen for diabetes during pregnancy so that we can detect these women and early enough to prevent adverse outcomes. And thank you very much, Professor Maddaloni, for reviewing for us the beneficial effects of metformin and its possible role in the treatment of women with GDM and type 2 diabetes. Before I end, I would like to remind everyone to please complete the post-webinar survey at the link provided in the chat or at the elearning.medeaacademy.com to download your certificates. We also would like to remind everyone that the recorded webinar will be available starting on October 25 on the Medea e-learning platform. So if you missed parts of the webinar, do not despair because you can still view them on demand at the Medea e-learning platform. And CME credits are available and the blended learning journey continues on because aside from this webinar, we have the video interview, the podcast, and the infographic all available on demand at the elearning.medeaacademy.com. And you may continue to follow us on our social platforms. We have our Facebook pages, the LinkedIn, the X, and even the YouTube. And please follow medea.com. And this has been your host for this webinar, Professor Nemesio Nicodemus Jr. thanking everyone for your participation and attendance to this live webinar. Thank you very much.